And we're very happy to have amongst us Dr. Christopher Beauchamp from the Mayo Clinic. He's a consultant in adult reconstruction and orthopedic oncology. He's a former chair of the Department of Orthopedics and the president of the Association of Bone and Joint Surgeons. He's actively involved in the design and the development of these 3D printed devices and combines that with an extensive clinical experience. So, the floor is entirely yours.
Thank you very much. It's a pleasure to be here. This is a topic near and dear to my heart. I have no financial relationship. This is Brooke. Brooke came to our practice about 6 years ago. She saw a colleague of mine, Dr. Mark Spangel, and she's a very unique individual who had a very complex orthopedic problem. In fact, had gone to a number of centers to try and come up with a solution about what to do with this problem. Brooke has a congenital dwarfism. She's 3 foot 10 inches tall, short stature, and has had a very primitive attempt at a salvage procedure many years ago to try and fix the disabling problem that she had with arthritis of both hips caused by her developmental problems. So she had a number of issues here with bad arthritis. She was very disabled. She was crutch dependent and was really desperate for some kind of relief from her pain. And then on top of that, she had these iatrogenic surgical deformities that were hampering any type of reconstructive effort. So this was the time when we became to realize the importance of 3D modeling, not just from what everyone first thinks of with 3D modeling, but it became very clear to us that there was an advantage to using the models actually as a surgical rehearsal surgery, if you will. So these are the actual size of her pelvis and femur, which you can see are very small. And we began our planning with surgery to actually operate on the models themselves. We created custom implants, both brooches and actual implants, and we were able to strategically plan the surgery, know exactly where we had to make the corrective cuts to try and restore the shape to her femur. And so we had an opportunity here in this very young individual to win big, or we could lose big. And the risks were quite high for her, and we were fortunately very successful in restoring her anatomy and creating for her very durable hip reconstructions, which are very critical, obviously, at a young age. And this is an example of her function currently. So it made a huge difference, but to us it really drove home the importance of not just 3D modeling, but the fact that it took our planning capabilities to the next level for these very difficult patients. And we have a very high volume of catastrophically failed joint replacements, difficult tumor reconstructive problems. And we went through the same back and forth with engineers and designs and trying to create implants for these patients, and realized that we really needed to bring this in-house. The delays and back and forth were too great, and it did create somewhat of an obstruction to actually using 3D modeling. So we took the step of bringing it in-house. This actually is right in our clinic. It's immediately available for us. Patients have a 6mm CT scan for high resolution imaging. It's relatively inexpensive compared to what we were doing before. And there's no question that rehearsal surgery is far better for our patients. It's faster in the operating room. It allows us to more comfortably perform surgery in these very difficult situations. So I think one of the quality of life measures that should be done is actually for the surgical team. because if we can make something that's very difficult a lot easier, it's obviously better for our patients. I think everyone's familiar with the techniques. I won't belabor this too much, but the scans are done and the DICOM images are automatically sent to a server for the surgeons to actually look at it. And we actually do it ourselves. We don't have anybody else manipulate the images. If it's a straightforward CT scan, I can get it up printing probably within a half an hour. So it's really pretty quick. And the usual steps, we use Mimics. So we have a Fortis printer. And this is an example of a patient that we're actually planning last week who has a bad acetabular problem. And all we're actually really interested in is the shape of the bone. The other parts of anatomy for this particular reconstructive effort we're not too concerned with. So obviously 3D modeling is helpful in difficult anatomic situations such as this patient who has a bone tumor that's involving one of the major arteries in the leg. But we want to use it to see if the reconstruction can be performed on the model. Are we able to use implants that are off the shelf, such as this type of reconstruction, which actually would work quite easily for this patient? Or do we need custom implants? And when we get into the field of custom implants, we then actually make it ourselves, or at least plan out what shape we want for this particular patient. So we're all kind of wrestling with the spectrum of trying to make the patient fit the implant or the implant fit the patient. So with conventional hip arthroplasty, obviously we're going to shape the bone to fit the implants that are available. But when we have situations like this, we have to actually make the implant fit specifically to the patient. And I think that's the whole area of patient-specific implants, is that they're obviously not needed most of the time, but sometimes we do need them. And then can we actually perform the surgery on the implant? So this is just an example of a patient with a large acetabular deficiency, and just shows the techniques that we do. It's fairly simple. We just do exactly what we would do in the operating room first. As a surgical colleague told me, an operating room is no place to think. So this is a good example of what I'm talking about. This is a 51-year-old woman, catastrophic failure, post-traumatic arthritis. A horse fell on her. She had an acetabular fracture, had 2 attempts at hip replacements, and now has this catastrophic failure with her acetabular component right through her pelvis. Modeling, traditionally, it became clear that there was nothing off the shelf that was going to work well for her, and we made a standard tri-flange type implant as described. This is a Biomed implant, and worked very nicely for her. And she has a satisfactory, solid reconstruction. Here's another patient with an even more difficult problem. She has her acetabular component is pressing against her bladder, and her femoral head is up against the lower part of her spine. And again, with the same defect, we began planning with standard implant trials, and then we build up the shape of the implant that I want with actually Play-Doh, and it gets sent back and forth to the engineers, and we ultimately manufactured a product made out of tantalum and implanted it. And this is just an intraoperative view. At the end of the prosthesis there is actually scar tissue surrounding her bladder. So it's that type of surgery that makes it very difficult. And we had a satisfactory reconstruction. Another patient, 65-year-old with an old dislocated hip, had a massive acetabular deficiency. And here we actually made the implant that we were going to implant in the patient. So this was a off-the-shelf trabecular metal acetabular component that we machined to fit her acetabulum and used it as a buttress. So we cut the acetabular implant sterilized it, and inserted it. And that greatly reduced the amount of time in the operating room and makes the reconstruction very much easy. It's straightforward. And this is an intraoperative photograph of the reconstruction as we had planned it. A final outcome. She's done actually very well with this and works well. Similar situation, 65-year-old male, became evident working with the model that off-the-shelf components weren't going to work. There was nothing there to support the acetabulum, and again, it made it very clear that any attempt intraoperatively of trying to fix this was not going to work, and the patient required a custom implant. We have other experiences with patients. This is a pelvic tumor, which we've been discussing today. This is a chondrosarcoma in a very active male, Harley-Davidson rider, very large acetabular resection, big tumor. And we were able to do the surgery based off his models preoperatively, in his reconstruction was with a compress acetabular component. And these are all of the cuts that were made off the model shape, standard reconstruction. And he's done very well. This particular type of resection and reconstruction is really fraught with a high complication rate. There's no real good answer for how is the best way to reconstruct this, but he's back to normal function with essentially the outcome that one would expect from just a total hip replacement. Also a very durable reconstruction. So we've become a little bit more sophisticated in our ability to communicate with the design engineers, and this is an example of a patient who has a significant problem with radiation effect on the acetabulum, and we needed an implant that was going to provide some support, a fairly simple cage device. We were able to actually shape this to the patient preoperatively and flash that, sterilize it, and we don't have to do all of the manhandling of the implant during surgery. But we are also able to communicate back and forth directly with the design engineers to tell them exactly what we have in mind. They've got the model, I've got the model, and we can communicate back and forth about what we need to try and really reduce that turnaround time of 6 to 8 weeks that it takes. And then this was an implant that this is our first go at a printed device, just going through the emotions of how are we going to logistically be able to do this and communicate back and forth. So in summary, we've found 3D printing, modeling, and rehearsal surgery an extremely powerful tool. It greatly facilitates the ease of which surgery is done on these difficult, complicated problems. It improves the care of patients. It assists in our accuracy of tumor surgery, in our ability to resect tumors, get a little bit closer to them, reduces our operating time, and it minimizes the need for what I refer to as MacGyverism in the operating room, which we really do a lot. We make things up as we go. We try different ideas, and really that's not the appropriate place to be doing it with this type of a problem. It should really be done prior to surgery. We've got a few areas that need improvement. It's very difficult with metal artifacts to get an accurate pelvis. That does consume a lot of time. Editing tools, I think, could be improved a little bit. We're only able to just deal with shape. We can't deal with quality of the bone, the texture of materials really do affect that, and I think that is the next step that we need to be looking at, is the realism of what we have to work with in terms of bone quality. Printing speed, our printer is a little slow, so I think we could upgrade one. We hope that will aid in the more rapid production of custom implants, as well as guides and instruments. And we're looking very much forward to metal printing, which I hope is going to greatly improve our ability to get these implants into patients much sooner. Thank you.